dialing in today and respectfully acknowledge their elders, past, present and emerging, as well as any members of the Aboriginal and Torres Strait Islander communities gathered amongst us here this afternoon. This Precision Cancer Program is a community of researchers, healthcare professionals and academics across Victoria that have an interest in precision medicine and particularly the application of such approaches to the care of cancer patients. The program, which has now been up and running and really quite successful and recently refunded by the state government, is working towards providing better access to molecular sequencing technologies for cancer patients, particularly in the southeastern regions of Melbourne and Victoria that have traditionally been poorly served in that regard. And also, and the program also seeks to provide support, particularly to referring clinicians regarding the interpretation and clinical implications of sequencing data that is obtained through such testing. And we do that via a series of MPCCC molecular tumour boards. And I'd certainly encourage particularly any members of the clinical and health care community, as well as the scientific communities to seek how they might join and contribute to those molecular tumour boards. So the seminars, of which today is the latest installation, are also an important part of the Precision MPCCC Precision Cancer Program. And they help to share the latest research activity across our partnership, as well as our state, and also international. We've actually had international speakers that have turned up, and particularly to help us communicate around new ideas and approaches to the clinical care of patients with malignant disease. So today's seminar, we're really looking forward to it, is going to cover some of the latest advances that relate to the evaluation and treatment of patients that have got hematological or blood-based cancers. And we're really excited to welcome our guest speaker today, Dr. Paul Yeh. So Paul's a real rising rock star in the academic hematology sphere. He's a consultant hematologist and also a clinician, card-carrying clinician scientist that's got dual appointments at Monash Health as well as Monash University. He's the head of the Blood Cancer Biomarkers Lab in the School of Clinical Sciences at Monash Health, and his lab's main interests are around the use of blood-based biomarkers to understand not only normal blood development, but particularly aspects of malignant blood disease. Like I said, he's a bit of a rock star. He's a finalist in the Victorian Premier's Awards towards the end of his PhD. This is the Premier's Awards for Excellence in Health and Medical Research, and also prestigiously a recipient of an international award for his translational research in hematology. Probably even more than that, he's a recipient of incredibly competitive emerging leadership fellowship grant from the NHMRC. And all those of us who've tried to get access to that scheme will realise just how competitive it is. He's got specific clinical interests in molecular hematology and malignant disease, and avails his role within Monash Health and the community to provide real bench to bedside to bench integration of care around his patients. So that's enough to do from me. Thanks very much, Paul, for accepting to talk to us. Welcome, I guess, formally to the Monash Uni affiliated precinct, and particularly to our seminar series, and we look forward to hearing from you today. Over to you.
Brilliant. Thanks so much, Mark, for that kind introduction. I'm just going to share my screen. So as Mark has said, let me just get rid of. So thanks everybody, and I'd like to thank the organisers for sort of welcoming me to the MPCCC to give this talk today. So my talk will be on liquid biopsy to understand blood cancer evolution. And as Mark said, I'm a hematologist by trade, but what interests me is really the laboratory side and the research side of hematology as well. And really, what I would really want, my research, our research to really sort of understand is the evolution of hematological malignancy. And that sort of stems from understanding what happens in normal blood development or normal hematopoiesis, and how that sort of evolves into malignant hematopoiesis or cancerous blood cancers. But also importantly, what my research interest is and what I want to talk about a little bit today is more about the understanding of what happens when we do have malignant hematopoiesis and we treat cancers. We invariably do get resistance or a refractoriness of disease from treatment. And therefore, understanding that therapeutic resistance is also valuably important in understanding how we can further treat blood cancers. So the two parts of my talk will be split into two. The first thing is I'd like to talk about sort of novel biomarkers in this space, specifically using blood-based biomarkers, using a blood test called circulating tumor DNA, which is what we use to get plasma DNA to try and profile malignant blood cancers. But also what we want to also do, what I want to also talk about is some of the work that we've done where we've tried to look at pre-malignancies. So, obviously trying to identify potential causes of malignancy before they become apparent is also important. And again, we'll try and use blood-based biomarkers or the whole blood in this case to try and see if we can get greater understandings of these pre-malignant conditions. So before we start, I'd like to talk about the plasma cell-free DNA first. And really, over the last 10 years, genomics and molecular profiling of cancers has really sort of increased our understanding of all cancers, notwithstanding hematological malignancies. But specifically for malignancies, profiling of the tumors that's now available gives us a better understanding of the tumor heterogeneity that occurs within cancers, but also allows us to identify molecular targets where we can potentially devise targeted agents for these specific cancers. But what really is a challenge for a lot of the clinicians and what our research understanding is understanding therapeutic resistance. Invariably, when we have a hematological malignancy and we treat it, we do get a response. But as you can see in this middle here, where you've got some cells here in color that are either drug tolerant as a result of therapy or acquire resistance of some sort due to the treatment itself. And although we've eliminated a bulk of the disease, these sort of cells can become stronger in the absence of, in the presence of treatment, and therefore lead to what we call clonal evolution or therapeutic resistance, which ultimately leads to relapse disease. And understanding this process is actually critical for us to really design the next therapeutic strategies. But how do we do that? And really, a lot of the research that we've sort of been invested in is to try and to address some of the current challenges that we have in monitoring this clonal evolution in hematological malignancies. The current problem is that a lot of the studies that we do currently look at one single time point. So either at baseline or when they're first diagnosed. And we really need methods where we can dynamically monitor these conditions and in real time so that we can get a sort of a running sort of results of what's going on within the tumor. The second thing is that trying to get sample to try and test this is inherently invasive in nature. So therefore, we want to have a way where we can alleviate the invasive nature of tissue biopsy that can be a burden on patients, but also the healthcare system as well, as these can be potentially quite resource intensive as well. What we're starting to understand about cancers, especially in heme malignancies, is that although we find cancer in one place, there might be cancers with different molecular profiles in other places or in other aspects of the body. So, having a means to get a profile of the cancer from multiple different sites is also very important. And lastly, sensitivity. Having assays that allow us to detect these smaller cells, as we can see in the red and the purple there, that we can actually pick these small sort of resistant cancers before they become fully relapsed and apparent and potentially too late for any therapeutic options. So herein comes plasma cell-free DNA, which has really become an in vogue biomarker in cancer diagnostics. Now, cell-free DNA consists predominantly of nucleosome-protected DNA shed into the circulation. And what that really means is that it's DNA that's shed from all cells that are turning over and released into the circulation. Now, in healthy individuals, we all secrete cell-free DNA. The quantity of plasma cell-free DNA is very low, but it varies from person to person. And what we know from research is that it's mostly derived from hematopoietic cells or blood cells. And that's, how we sort of separate that in real time, in real life, is that this is a pictorial, is we spin down the blood cells and we see the plasma cell-free DNA there. Now, the biology of cell-free DNA is very interesting, and this is how we sort of harness it to try and detect it in cancer diagnostics. Now, cell-free DNA is more fragmented than DNA that we see in the normal DNA. It's usually about 170 base pairs or 150 wrapped around a nucleosome plus a 20 base pair linker fragment. And it usually represents nucleosome footprints that can be used to infer the tissue of origin. And again, the vast majority is from hematopoietic tissue, but we can also use ctDNA to identify tumor tissue of origin. And this is just a pictorial of what sort of a cell-free DNA is that these fragments can either represent one, DNA wrapped around one nucleosome, or sometimes they can split one and can cover two nucleosomes as well. Now, how is cell-free DNA released? I've mentioned a little bit about how it's released, but three main processes are thought to cause release of cell-free DNA. Apoptosis, which is necrosis, where the cells are dying, and also active secretion by the cells as well. So these are the general three ways that cell-free DNA is sort of secreted. And if you can think about how cancer sort of evolves, there's a lot of cancers have high rates of apoptosis, necrosis, and secretion. We can potentially use this to harness using methods to try and see if we can pick up DNA that's specifically shed from tumors into the circulation. So here I sort of wanted to show the difference between cell-free DNA and circulating tumor DNA. Now, cell-free DNA is what I've mentioned before, is DNA shed from all tissues. So these are normal and in fairly low amounts in healthy individuals. Circulating tumor DNA is cell-free DNA specifically shed from tumor cells. And how do we know that how do we differentiate between these two DNA strands? Well, inherently circulating tumor DNA is even shorter than normal cell-free DNA. And you can see that in studies, in many studies, you can see that DNA from healthy donors, cell-free DNA from healthy donors, is inherently 20 base pairs longer than that of a patient here with a melanoma, where the fragment of the DNA from the tumors is actually a bit shorter. So we can use that to harness and try and see how we can pick up circulating tumor DNA within the blood. So really, the idea of circulating tumor DNA in cancer, or ctDNA, is to provide a liquid biopsy where, for example, this patient B, where you have a tumor, but you can't access it either due to a patient not being very well, or a very technically difficult way to biopsy a patient. We try to use the blood and cell-free DNA to try and see if we can get some molecular information from that tumor to help either make a diagnosis or help with therapy. And one way we can do this is, apart from looking at the normal cell-free DNA, which is that DNA strand just as an example, we can look at ctDNA, which is inherently a little bit shorter. But also what we can do is we can look for specific mutations that might be very specific to that tumor or that cancer. And that's potentially how we can use this as a means to detect cancer, by detecting somatic mutations or acquired mutations from the tumor in plasma as a disease monitoring tool. And we've got different methods of detecting cell-free DNA or ctDNA in cancer. And these sort of range from just looking for one single mutation or one area using single locus assays such as digital PCR, to more sort of widespread sort of screening tools such as exome sequence or whole genome sequencing. Now, these are going to have various different strengths and weaknesses, but in general, as you increase your sensitivity, you're going to decrease the areas that you're going to look for, and therefore trying to find that right balance in terms of what we look for in terms of finding the best assay for ctDNA detection is always going to be critical. And that's what we, as molecular pathologists and also researchers as well, are trying to define the best way to screen for disease is very important. So ctDNA has been used a lot in solid malignancies in research and also potentially in diagnostics field, but how about in hematological malignancies? The thing is that, a lot of skeptics would say that hematological malignancies have a leukemic component. And if there is, if there are tumor cells in the peripheral blood, is it actually needed to, do we actually need to look at cell-free DNA where we can get tumor cells already from the peripheral blood? But I guess this is sort of where our research sort of comes in. And we really want to explore the use of ctDNA in lymphoid and myeloid malignancies where there is a potential reason why having a ctDNA is going to be beneficial. And the two examples I want to give are in chronic lymphocytic leukemia and myelodysplastic syndrome. So the first thing I want to talk about is chronic lymphocytic leukemia. For those that know, it's the most common adult leukemia in developed countries. And what it is it's a clonal proliferation and accumulation of mature B cells within multiple compartments, not just the blood. So you can see tumor cells in the blood, but you can also see tumor cells in the bone marrow, lymph nodes, and spleen. It's largely incurable, but there's slow progression in most cases, which means that clinical management and identification of the correct patients that we need to treat and treatment decisions is very critical. So in the last 5 or 10 years, new drugs have really come to the fore, where previously we've had broad-based chemotherapy approaches, which have been highly toxic. But now novel therapies have really paved the way in CLL, and they've targeted specific pathways that are associated with CLL, and those being the BTK pathway, which ibrutinib, which is an inhibitor of BTK, but also venetoclax, which is an inhibitor of BCL2. And targeting these two pathways have really revolutionized the way that we've treated CLL, and with amazing results. However, with these new drugs, we need to find good ways of monitoring disease to see whether we are actually winning with therapy or whether actually we're losing with therapy. And therefore, there are some current limitations of the way that we monitor CLL at the moment. At this point in time, each of these drugs would mechanistically act on CLL in a different way, and therefore it exposes the limitations of what we do currently. Currently, when we monitor CLL, we do multiple different ways of assessing disease through a blood test on the left, clinical examination on the right, but also scans, sort of X-ray, CT scans, PET scans, and also flow cytometry. So we actually use a lot of different ways, and there's no real one great modality to say that this is the ideal way of monitoring disease. So really this provides new novel opportunities for monitoring techniques, which is either through molecular testing and cell-free DNA. And this is sort of where we come to our study design, where we looked at 32 patients with refractory CLL that were embarking on either of these two new agents, venetoclax or ibrutinib. And we also had matched MNL DNA, which is DNA from the blood, which is the tumor cells in the blood, to see if there's any difference between just looking at the cell-free DNA, which is the plasma, or the tumor cells in the blood as well. So see if there's any difference at all. And what we did was, in these patients, we did a targeted sequencing panel, essentially looking at 7 genes that we knew that were recurrently mutated in CLL. And we used that to find a mutation and track these patients through throughout their therapy to see whether we could track cell-free DNA mutations throughout their therapy to either predict response or predict relapse. And I just wanted to highlight a couple of cases from this research to show the power of ctDNA. So in this case, I want to highlight that ctDNA can correlate with the overall disease burden across tissue compartments in CLL. Now, this patient here that I wanted to highlight was treated with the drug ibrutinib. Now, clinically, one of the sort of unique things about ibrutinib therapy is that we sometimes see a worsening of peripheral blood lymphocyte counts in the context of ibrutinib therapy. And what that means is that people can falsely believe that the drug is not working, especially if the blood lymphocyte counts, which is what we usually do to track the disease, goes actually up in therapy. But what's actually happening is that all the disease is coming from the lymph nodes and being transferred into the peripheral blood. But overall, that, after a period of time, the patients are actually responding to therapy. And you can see that here in this graph here, and I'll just take you through this slowly. What we can see is this PBL count, which is the peripheral blood lymphocyte count. When they start their therapy, it starts from here, and then it goes up in the response to therapy, but then drops after, close to 200 days, signifying their response to therapy. And you can see that at this time point here, when we tested the mutations of the peripheral blood mononuclear layer, which is reflective of the tumor in the peripheral blood, we can see that the mutant burden, so the amount of mutation that we can see from those cells, actually goes up in the context of therapy, but then subsequently goes down. But interestingly, what we actually see in cell-free DNA is that it doesn't go up, but it actually follows a downward trend all the way through, suggesting that the ctDNA is potentially capturing what's happening throughout the whole body rather than just the blood compartment. And you can see that that's probably more reflective of what's happening radiologically, where the patient here has started off with disease, but has responded really well after therapy with ibrutinib. So this sort of highlights the power of ctDNA in this sense. And that's actually, better representation of the overall response to therapy rather than just the peripheral blood as highlighted here. Now, the other thing I wanted to highlight is ctDNA's capacity in a condition called Richter syndrome. Now, Richter syndrome is a transformation of patients with CLL that transform into a more aggressive disease, a larger cell transformation. Now, this is invariably a poor prognostic sign. And although the molecular pathogenesis is largely unknown, people think that the acquisition of TP53 mutations or deletion 17p are frequent events that we see in Richter syndrome. So, Richter syndrome is clinically a diagnosis that needs to have high clinical suspicion and accurate tissue biopsy to sort of differentiate smaller CLL cells from larger Richter cells on the right. And you can see we had a patient that had, in this study, that had Richter syndrome in the bone marrow. And you can see that this patient had venetoclax therapy. And you can see they started off with a lot of the CLL, which is a lot of small cells here. But at day 155 in the bone marrow, you can see that not only did they have these small cells, but they have these large, very disorganized areas of cells as well, representing Richter's transformation. And on the PET scan, we could also see areas of very high metabolic uptake in places that were not bone marrow or the blood, suggesting, again, of Richter's transformation. And the interesting thing is that when we looked at cell-free DNA, we could actually predict the onset of Richter's occurring. Now, in this is the plasma. So this graph shows what we found in mutation perspective in the plasma. And you can see that we, firstly, at the start of venetoclax therapy, in the cell-free DNA, we found this mutation in green here, this TP53 mutation. As we treated with therapy, the mutation burden started to go down and down and down. But at the time of Richter's transformation, this mutation wasn't seen. But what we could see was that we could see the emergence of new mutations in TP53, which is the frequent event in Richter's, but also an SF3B1 mutation that sort of arose in the context of therapy. And you can see that this probably suggests that a divergent pattern of clonal evolution here, where that's, how I said that initial sort of schematic where you've treated a lot of the bulk disease, but there is one sort of small cell there that might have been resistant or acquired resistance that has sort of grown out in the context of therapy. So this is a sort of molecularly, this sort of is a sort of a representation of that. But what's interesting is that although we could see that in the plasma, and although we could see this acquisition, various, at least, 50 to 60 days before the onset of Richter's, we couldn't see that by just sequencing the tumor or the mononuclear layer in the peripheral blood. And you can see that although we could detect that mutation, that green mutation in the peripheral blood, at the time of Richter's, we could not see any of those mutations that we could see in the plasma, in the mononuclear layer or the tumor cells within the peripheral blood, suggesting in these sort of cases we can't just sequence the tumor cells in the peripheral blood, and plasma was able to pick this up better than the peripheral blood. So in summary, what I wanted to highlight from this study was that molecular monitoring highlights the compartmentalized nature of CLL, especially in disease progression and transformation, and that you can't just sample one compartment to get the information that you have from all diseases, from all parts of the body. And therefore, ctDNA can monitor disease and predict treatment failure in patients with CLL. And also, ctDNA can capture genomic information from multiple disease compartments. So I want to go on to MDS now, which is the next disease that I want to show the highlight of ctDNA. And MDS is a clonal hematopoietic stem cell disorder where people have low blood counts or cytopenias, ineffective hematopoiesis, and increased progression to AML. Now, it's mostly in the elderly, and it's largely incurable without a stem cell transplant. And the gold standard for diagnosis is a bone marrow biopsy. Now, the only sort of treatment that's currently approved for MDS is azacitidine, which is a hypermethylating agent, and it has a proven survival advantage in both MDS and AML. However, only approximately 50% will respond to therapy, and response can take up to 6 months. So therefore, even though that if there is a response, most will invariably progress to AML. So really, we need to understand the precise mechanism for response and failure, especially if it's going to take 6 months to potentially work. So we know when to push on or when to stop. So therefore, we do need to have these good methods of diagnosing and monitoring disease. So you can see that this is where ctDNA can potentially help, because bone marrow morphology can be subjective and difficult. And in pathology, when we look at bone marrows in the microscope, we have to differentiate between all of this, what's a blast, or what, the different types of cells that make a diagnosis of MDS under the microscope every time. And it can be highly subjective. The other thing is that trying to get sample is, again, invasive, using, needles, sometimes a drill, to get that biopsy sample that we need to make an accurate diagnosis. It can also be variable due to fibrosis or lack of cells as well, or hypocellularity. So really, we wanted to see whether ctDNA could help in this sort of sense. And we looked at 12 patients embarking on azacitidine-based therapy, and again, looked at see whether we could track mutations using a sequencing panel throughout their therapy. And what we were able to show, again, like CLL, is that we were able to demonstrate clonal evolution, but we could also predict impending treatment failure. As you can see, all these sort of colored lines are mutations that we sort of detected at the start and were able to track throughout their therapy, along with other things that we could look at, peripheral blood, bone marrow blasts, and also peripheral blood counts. But you can see at this pre-progression time point, you could see this sharp rise in all the mutations that we detected at the onset, plus a new one as well. And you can see that we saw that even though the blood counts were probably not too bad at that time, but then, a couple of hundred days later, the patient actually progressed, where the blood counts dropped and the blast counts increased. So again, we were able to use ctDNA to predict the fact that this patient was about to progress on therapy much earlier than what we could from just a blood count. The other thing that we could do was not just look at mutations, but look at changes in chromosomes or karyotypic changes. And this is sort of whole genome sequencing, where we can look at baseline, where you can see this patient had a loss of in 9q, and that sort of went away in response to therapy. But at that pre-progression time point, we were able to pick that up again, highlighting impending treatment failure. So in MDS, we could track multiple genetic lesions that we can throughout therapy in ctDNA, but and we can see differential responses. We can see some clones going down, some clones going up. So again, highlighting that we can track these sort of disease-causing mutations in real time. And we could also predict treatment failure. But also what happens is that it correlated extremely well with bone marrow samples at that time as well. So I guess in summary, how we've sort of seen a couple of things that we've learned from our research really is that as a proof of principle, ctDNA can be a useful tool in disease monitoring in MDS and CLL, where it's a minimally invasive, can capture the underlying genomic landscape, represent treatment responses over time, and track tumor kinetics across multiple disease sites, but also detect changes that confer resistance or clonal advantage. So, I've sort of talked about where things are currently at with sort of some of the research and where things are at with ctDNA and heme malignancies. And so far, I've sort of focused on mutations and chromosome changes and being able to detect copy number aberrations. But I guess the next thing that we're sort of embarking on is to look at other ways that we can look at cell-free DNA in cancer. And one of these I want to briefly talk about is that of gene expression profiling using cell-free DNA. And the premise is that cell-free DNA is fragmented in a very specific way, and that we can use the way that DNA is fragmented and the way that it is sort of degraded within the circulation to sort of help infer gene expression on cancer. So, for example, the premise here is that cell-free DNA, when it's been expressed, will invariably have lower sequence coverage over areas. So, therefore, we can infer that the genes are turned on. Whereas if we don't see any changes, then it is turned off. And I wanted to sort of highlight some research that we've got going at the moment, looking at SNIPER, looking at bioinformatic ways where we can look at inferred gene expression. And that firstly involves sequencing of low coverage of plasma circulating DNA, aligning that to the reference genome where we can look at coverage patterns or fragmentation patterns over certain genes, and therefore normalizing and then inferring that the gene expression pattern that are potentially arising from tumors to try and get not only a genomic profile, but a gene expression profile. And we can see here that in some preliminary data that our SNIPER method can show concordance with gene expression profiling from bone marrow RNA sequencing as well. So that's some of the research that we've got going, and I think is probably an added armamentarium in our sort of our ctDNA research and also the field as well. So having talked about cell-free DNA, I wanted to talk a little bit about the next aspect of my research interest, which is clonal hematopoiesis, and trying to understand the pre-malignant condition clonal hematopoiesis, because what's happened in the last 10 years is that there's been a lot of research in this space. And really it's come out of the fact that clonal hematopoiesis is defined by a clonal expansion of hematopoietic stem cells that are driven by somatic mutations. So what you have is that there's many studies that have found in healthy individuals when they've taken blood and they've sequenced them, a small proportion of them will have a mutation or somatic mutation in a small proportion of their blood cells. Now, most of these mutations are in genes associated with myeloid malignancies. And although relatively common, probably more common than you might think, The interesting thing is that these large studies have found that there has been an association of clonal hematopoiesis with increased risk of hematologic malignancy, cardiovascular events, and all-cause mortality as well. And really, the mechanism by that is that there is a proposed reason that there might be an associated with increased inflammation. At the moment, the only risk factors that we know for clonal hematopoiesis are age. So those that are older have a higher risk or higher incidence of clonal hematopoiesis to the point about 10 to 15% of people over the age of 60s will have this without having a hematological condition. The other risk factor is chemoradiotherapy. So those people that have had chemotherapy or radiotherapy would be at a higher risk of clonal hematopoiesis. And you can see that in a lot of these the studies that we see. This is from Sid Jaswell's paper in 2014 showing the increased incidence of clonal hematopoiesis according to age. Now, part of the research, or part of what we sort of found was interesting, is that there must be other reasons why clonal hematopoiesis potentially occurs. Now, and what we wanted to look at is immunocompromised states. What we know at the moment, or what we know as a potential association, is that clonal hematopoiesis increases your risk of hematological malignancy, cardiovascular events, and all-cause mortality, potentially through an inflammatory response, and the increased age and chemoradiotherapy as potential risk factors. But what these two states potentially represents is that of potentially immunocompromised state. We've known through COVID and things like that, people that are older are potentially more immunocompromised, and definitely patients that are undergoing chemotherapy are more immunocompromised. So could this be the reason of more development of clonal hematopoiesis? So we wanted to really test that hypothesis, and that other immunocompromised state could enrich for clonal hematopoiesis. And the first setting we wanted to look for is allogeneic stem cell transplantation, because allograft or allogeneic stem cell transplantation is a curative therapy for a lot of bone marrow failure syndromes and also hematological malignancies as well. However, although a curative therapy, it's got significant morbidity, such as disease relapse, heart disease, secondary malignancy, and a condition called graft versus host disease. So therefore, donor selection, and what allograft is that you have a donor, usually of a sibling or an unrelated, matched unrelated donor, and you transplant their stem cells into the recipient to try and get an immune response or an immune therapy to wipe out any small levels of hematological malignancy in the recipient. So therefore, the donor selection is very important, and there's this sort of philosophy that the older donors that you have, the older the donor is, the poorer the outcome is. Now, if you think about it, the older donors, disease relapse, heart disease, secondary malignancies, they're all sort of potential complications of clonal hematopoiesis. Could the reason why we're getting potentially poorer outcomes be related to clonal hematopoiesis in the donor? And therefore, if I take you back through that model, allogeneic stem cell transplant can potentially also cause everything above there. But what if the reason for all that higher risk is through clonal hematopoiesis, where that they have an increased inflammatory response as a result of having a donor that has clonal hematopoiesis? So we really wanted to test that theory out and look at clonal hematopoiesis in allogeneic stem cell transplant donors. So the first aim was really a biological look at whether the incidence and survival of donor clonal hematopoiesis in allogeneic stem cell transplant. So we screened using liquid biopsy, whole blood DNA in the donors to see whether we could identify donors that had clonal hematopoiesis. And what we did was that once we identified these donors, see what happened to the recipients when they got transplanted, and this was a retrospective study, and then see what happened to their clone in the context of therapy. But more importantly, if that did happen, what was the influence of having a donor clonal hematopoiesis was? So what was the actual clinical outcome? Did it actually predict for better or worse stem cell transplant outcome? And our study did find the presence of clonal hematopoiesis in our stem cell donors. In fact, in 13%, which is not too disproportionate to what we've found, what the general population is. What we did find was that when those patients that did have clonal hematopoiesis, is that when it engrafted or when they were transplanted into the recipient, they were all of them engrafted. So you could see the the mutation there after transplant, but not only that, it increased in size at serial time points after therapy as well. But what we didn't find was an association with poorer outcomes. And these graphs, although there is a trend, were not statistically significant. So overall, we could not find any significant survival or adverse sort of survival outcome between a patient that received a donor with the clonal hematopoiesis or without. But what we did find was that when they did sort of engraft, a lot of these cells tend to gravitate towards the myeloid compartment, probably suggestive of the fact that these mutations are more prevalent in myeloid type genes rather than lymphoid type genes. This is just something quite interesting where we've shown that although we've engrafted donor clonal hematopoiesis, it was also associated with restricted T cell diversity post-transplant, suggesting that potentially the engraftment of the clone of the donor clonal hematopoiesis might in some way shape the immune system after your transplantation. And with that, in some cases where we saw patients with chronic graft versus host disease, where a patient has their donor T cells attack host other organs such as skin, gut, we could see that this patient here also had an increasing burden in their clonal hematopoiesis, suggesting that maybe the presence of that donor clonal hematopoiesis could have contributed to chronic graft versus host disease. But this is sort of very preliminary data, and we do need to flesh this out a little bit more. So this is sort of avenues for further research. So in summary, donor clonal hematopoiesis in this context was not associated with any adverse outcomes in allogeneic stem cell transplantation. And that engraftment of the clonal hematopoiesis in the short term showed sort of an increasing burden in myeloid cells, but also restricted T cell diversity as well. So we know that from this, what we've learned about clonal hematopoiesis was that the donor clonal hematopoiesis can survive in another host, but also we do need to know a little bit more in terms of what, the true consequences of having a donor with clonal hematopoiesis is, to sort of suggest the need, whether we actually do need wider screening for stem cell donors to try and improve the patient outcomes in transplantation. The last bit, or the last little bit of research that I want to talk about in clonal hematopoiesis in blood cancer, potentially important in blood cancer development. And the reason why this was important was that patients with, the clinical problem was that patients with HIV are actually